Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're beginning a brand new series entitled, What's the Point? And this is part one of this new series, and in this section, in this part, I want to talk to you about the important points related to the physical examination. And the purpose of this discussion is to help you separate out your findings by physical exam into those findings that are subjective findings and those findings that are objective findings. Now you'll recall that the AMA guides are all about objective findings. And sometimes we consider our physical examination procedures that we do, we consider them to be objective tests when in actuality they're not objective tests. In fact, most of the physical examination procedures and maneuvers that we employ are completely subjective maneuvers. Range of motion maneuvers are totally subjective, meaning they're totally under the will of the examinee. Orthopedic testing maneuvers that we employ, for example, in the lumbar spine, such as Kemp's test, Milgram's test, double leg raise, prone double leg raise, Gainsland's test. These are all almost completely subjective tests. So what I want to share with you in this discussion is how can we take tests that are otherwise largely or completely subjective, how can we take those tests and introduce more objectivity into those tests so that those tests become actual reliable and valid indicators of the examinee's true condition? How can we make these tests that are supposed to be objective tests, how can we make them actually objective tests? So the recurring theme throughout this discussion related to the physical exam has to do with the nature of true objective findings. The nature of true objective findings. And I want you to think about that for just a couple minutes. True objective findings. You know, so many times I talk to doctors and I ask them, well, what were your objective findings? And doctors will tell me, well, there was a positive straight leg raise, and there was a positive Kemp's test, and there was a positive Phelan's test for carpal tunnel syndrome. And I stop the doctors and I say, now wait a minute, now explain to me, what is a positive Phelan's test, or what is a positive straight leg raise test? And the doctor will tell me, well, I did the straight leg raise maneuver on the examinee, and the examinee reported pain in the distribution of the sciatic nerve, or in the distribution of the tibial nerve, or in the distribution of the common peroneal nerve, or whatever. And I wait for the true objective finding, when in actuality all the doctor did was share with me the examinee's subjective report of pain with the maneuver. And I'll tell the doctor, that's not an objective finding at all. That's not an objective finding. A report of pain on a physical examination maneuver is not an objective finding. Do you get it? It's totally subjective. But these maneuvers, the straight leg raise maneuver, the Phelan's maneuver, Kemp's maneuver, and all these physical examination maneuvers that we employ can be made to be more objective with a couple of key insights. And that's what I want to share with you in this discussion series related to the physical exam. Now today I want to talk to you about one of the few true objective tests that we actually have. And if you think about all of the physical examination maneuvers and procedures that we employ, very, very, very few of those qualify as truly objective tests. What are some of the truly objective tests that we have? Measurements for atrophy, that's a truly objective test. The other one, the other main one, just off the top of my head, and I'll just go on record as saying the other main truly objective test that we have is reflex testing. So today I want to talk to you about reflex testing. Now, reflex testing is so important. Reflex testing is super important, and the reason it's super important is because it is a truly objective test. meaning that the examinee has no control, no input, no say or contribution to the outcome of the finding of reflex testing. So in that sense, it's a truly objective test. And despite what the examinee might say in terms of their subjective complaints, reflex testing gives us a true look into the function of the nervous system. Now, reflex testing is mostly described in Chapter 15 of the AMA guides with regards to radiculopathy, but we also use reflex testing throughout the body for examination of the upper extremities, for examination of the lower extremities, for examinations of the cranial nerves. But for our purposes and just for illustration purposes, we're going to limit our discussion today to the use of reflex testing for the evaluation of radiculopathy. So this is described in Chapter 15 of the AMA guides. So I want to set the scene for you, and I want to establish the case. The case involves, let's say, a 40-year-old male who describes a lower back injury at work and comes into the evaluation complaining of symptoms that could be consistent with what we consider to be radiculopathy. Let's take a look at how reflex testing can help us to determine whether or not the examinee has true, bona fide, and verifiable radiculopathy, or whether the symptoms that the examinee is reporting more closely qualify as non-verifiable radiculopathy. Okay? So let's get out the whiteboard and go over a couple of key insights related to reflex testing. Okay, I'm back with you now, and I hope you can see the board here, and I hope you can see me here as well. I've taken the liberty to draw a couple things here on the whiteboard. I have here a lower extremity of our examinee. This is the thigh, this is the lower leg, and believe it or not, this is the foot. And what I've drawn in here for you is the gastrocnemius muscle here. And what we're going to do is we're simply going to assess some anatomical considerations related with reflex testing of the Achilles reflex. Okay? So let's talk first about the components of a reflex arc. Okay? Now the first component of a reflex arc involves the stimulus. So here we have our hammer. Our hammer is going to serve as the stimulus to initiate the reflex arc. Okay, so that's the first component of a reflex arc. Now, second component of a reflex arc involves a sensor. And in this case, the sensor is located deep within the belly of the muscle, and this sensor we refer to as the muscle spindle. So that's our number two component of a reflex arc, which is the sensor, which is a muscle spindle. Now it's interesting, muscle spindles, if we draw in spinal cord here, and let's change colors so you can see a little better. If we draw in the spinal cord, that's not very good. I'm sorry. We draw in the spinal cord here. Central canal right here. This would be dorsal. This would be ventral. Okay, so let's draw in the innervation to the muscle spindle. Recall that muscle spindles have afferent axons that project into the dorsal horn. Here would be the cell body here in the dorsal root ganglia. They're also innervated by motor axons that help to maintain and establish the resting tone or tension within the muscle spindle. Okay? So there's the innervation of the muscle spindle. And then in addition to that innervation, we have also motor neurons innervating the gastrocnemius muscle itself. Okay? So the components of a reflex arc include a sensor. The sensor sends signals up the sensory afferent neuron, which creates a synapse in the spinal cord, enters the dorsal root, makes a monosynaptic synapse with motor neuron here in the ventral horn, and then also makes a synapse with a motor neuron that innervates the muscle spindle. Okay, these motor neurons are the gamma motor neurons. These motor neurons that innervate the gastrocnemius are alpha motor neurons, the larger alpha motor neurons. So we have a sensory input coming in, we have motor output coming out, we have the spinal cord here, which is component number 4, motor output here, which is component number 5, and then here we have component number 6, which is the gastrocnemius muscle. We refer to that as the effector. The effector. It's at the end of the motor neuron. It carries out the impulse carried by the motor neuron. The gastrocnemius muscle is the effector, or the end organ. Okay, so let's review what happens. The stimulus comes along and percusses down on the Achilles tendon. If the stimulus is brisk and strong enough, it causes a rapid stretch in the muscle spindle. Now the membrane of the muscle spindle is continuous with the paramecium, the connective tissue, on the outer layer of the gastrocnemius muscle. Remember, the 3 layers of connective tissue in muscle is perimecium, epimecium, and endomecium. All of those are confluent and continuous with the Achilles tendon. So as the Achilles tendon is stretched, it stretches the paramecium, which tugs on the muscle spindle and creates an afferent volley of impulses that ascend towards the spinal cord. Now this sensory neuron here travels in the tibial nerve. This is located, one of thousands and thousands of sensory neurons located within the tibial nerve. So it travels up in the tibial nerve and enters the spinal cord at least in the S1 region. Now we know that the tibial nerve is innervated by L4, L5, S1, S2, and S3. But the Achilles reflex is primarily considered an S1 reflex. So for our purposes, we'll say that this afferent volley enters the spinal cord at the level of S1. Now remember, the spinal cord itself ends at around the T12 to L1 level of the spinal column. So the S1 level of the spinal cord is located somewhere around T12, T11, T12, in that region of the spinal column. It's located around the T12 vertebra. Okay? And then here there are various interneurons, probably interneurons that ascend to L5, that ascend to L4, that descend to S2 and S3. But let's just simplify our discussion and consider the S1 level of the spinal cord. Well, this afferent impulse makes a monosynaptic synapse, monosynaptic connection with the large alpha motor neuron, which then sends an efferent volley of impulses towards the effector, And these efferent neurons also travel in the tibial nerve, and they arrive at the neuromuscular junction, NMJ, of the gastrocnemius muscle, release acetylcholine, initiate depolarization of the membrane of the sarcolemma of the muscle cells, and we get a contraction of the gastrocnemius to cause plantar flexion at the ankle joint. Okay? So, isn't that amazing? We have afferent volley, we have efferent volley. These travel in the tibial nerve, the efferents travel in the tibial nerve. They enter the spinal cord at least the S1 level, probably also the L5 level, probably also the S2 level, but for our purposes we're simply considering the S1 level. So here's what I want you to think about. Here's what I want you to think about. You have an examinee who comes in and he describes symptoms that are consistent with what we would consider to be radiculopathy. He talks about loss of sensation in the ankle and foot, pain in the back of the calf, describes sometimes catching his foot on curbs and on steps because he's clumsy in the foot, and he's weak on rising up on his toes. And he describes sensory symptoms, pain symptoms, and motor symptoms that sound like they could be radiculopathy. Okay? But those are all subjective reports. A report of numbness in the foot is not the same as numbness in the foot. In fact, we don't really have a truly objective test to identify numbness in the foot, although we'll talk about our sensory exam in another discussion in a week or so. So the examinee has these subjective complaints. We then go ahead and we do our Achilles reflex testing, and we find we obtain a brisk plantar flexion of the foot. What does that tell us? What can we conclude? Well, what we can conclude from normal reflexes is that a lot of structures, here, repeat after me, a lot of structures have to work properly in order to be able to generate a normal reflex. Okay? Let's look at the structures that are functioning properly. Okay? When we get a normal reflex, we know that the sensor, the muscle spindle, is functioning properly. We know that the afferent axons traveling within the tibial nerve are functioning. Therefore, we can start to conclude that the tibial nerve itself is normal. It's not damaged. It's functioning. We know that at least the S1 level of the spinal cord is healthy, because disease and damage here in the spinal cord can disrupt these synapses and produce reflex changes. In the presence of normal reflexes, we can conclude that the S1 level of the spinal cord is functioning normally. If the S1 level of the spinal cord is functioning properly, where do these afferent axons come into the S1 level of the spinal cord? They come in through the S1 nerve root. We know that the S1 sensory nerve root is normal. If we have a normal reflex, we know that the efferent neurons traveling in the tibial nerve are normal. Where do these efferent neurons exit the spinal cord? They exit the spinal cord at the S1 nerve root, the ventral root, the motor root. We know that the S1 nerve root is healthy. We know that the tibial nerve is healthy. We know that the neuromuscular junction is healthy. We know that the end effector organ, the gastrocnemius muscle, is normal. A whole lot of structures have to function properly in order to produce normal Achilles reflexes, normal patellar reflexes, normal hamstring reflexes, etc. When you have normal reflexes, it tells you a lot. It tells you that the entire loop, the entire reflex arc, and all of the multiple components within that reflex arc are normal. And the true objective finding in this case, the presence of a brisk reflexes, is a true objective finding for preserved and intact function of many structures despite the examinee's subjectivity. Okay, doctors, so normal reflexes are a negative finding for radiculopathy. So despite the examinee's subjective complaints of sensory disturbances, motor disturbances, pain, and what appears to be the distribution of spinal nerve roots, the presence of normal reflexes is a negative finding for radiculopathy. Now, how can you report your findings in your physical exam section of your report to indicate to the reader that this is a negative finding for radiculopathy? Well, I used to spell out for the reader all of the components of the reflex arc that are functioning normally when the examinee presented with normal reflexes. So, for example, I would present a table in my report that had the reflexes and the findings. And then below that, I would give some descriptive statement, such as the following. Reflexes were normal and symmetric bilaterally at the knees, or at the patella, at the hamstrings, and at the Achilles. This indicates preserved and intact function of colon. And then I would list out all the components of a reflex arc. I would say, number 1, gastrocnemius muscle spindles. Number 2, sensory neurons, sensory nerves traveling in the tibial nerve, S1 level of the spinal cord. Motor nerves traveling in the S1 nerve root, motor nerves traveling in the tibial nerve. Normal function of the nerve, and I used to list all the components to indicate to the reader of the report that despite what this examinee says about their symptoms, all of these structures are functioning normally. Well, I've since found that to be not necessary, and I've since found that to be a bit overkill. I believe it's simply sufficient to say when you report your findings on reflex testing to report your graded scores on reflex testing. Normal reflexes are typically either +2 or +3. And then simply tell the reader that the lower extremity reflexes were normal and symmetric bilaterally, and then tell them what that means. Tell them what that means. What's the point? What's the point? Here's the point of this whole discussion. In the next 2 sentences, you put this in your report. Number 1, this is a negative finding for radiculopathy. That's the point. Number 2, this indicates preserved and intact function of spinal nerve roots and lower extremity peripheral nerves. And it tells the reader that the examinee's nervous system is functioning normally, that this is a negative finding for radiculopathy, and that at most, the most the examinee could possibly qualify for would be non-verifiable radiculopathy. Now, do you see how valuable this reflex testing is? In the presence of normal reflexes, let me ask you, do we need electrodiagnostic studies? No, we don't. The nerve function is preserved and intact. Don't order electrodiagnostic studies in the presence of normal reflexes. What about MRI studies? Do we need MRI studies to investigate a lumbar disc when we have normal reflexes? We don't. We don't. We rely on the truly objective findings in this case, and we secondarily consider the examinee's subjective complaints, but our decision-making process is based on the true objective finding. And I want you to repeat this over and over again to yourself as the take-home message, and this is the point. We rely on the true objective findings primarily, and secondarily, we rely on examinee subjectivity. And that's why I love reflex testing, and I encourage you to become a meticulous reflex tester. And you can rely on those findings as true indicators of the examinee's current level of function and as a true indicator of their current condition. And this allows you to provide for appropriate recommendations for medical care, should that be necessary, or if the examinee is permanent stationary. This helps you in providing your opinion for or against permanent impairment, for or against any apportionment, and will help you in your decision-making process. So doctors, I hope this helps you. The point is, always look for the true objective finding and rely on the true objective finding for your decision-making process. Okay? I hope this has been helpful for you. It's been my pleasure to be with you here today, and I look forward to being with you on our very next video as we continue our new series entitled What's the Point? Focusing on the physical examination. So for now, this is Dr. Perry Carpenter, wishing you best of success in your career as a qualified medical evaluator.